I get questions all the time from members of the soft tissue revolution, and I like making videos. So I got a question about a spondylolisthesis. I have trouble saying that, but essentially it says, "Morning group, Dr. Matt, what are your recommendations for a client with a spondylolisthesis level 2 for corrective exercises and proper treatment? Client's pain isn't severe and doesn't interfere with daily life. However, client is almost 50 and been experiencing off and on discomfort for a while. Client is extremely active with gym, yoga, and golf. I hear rotation exercises should be avoided with this diagnosis. He went to a chiropractor and they said it's most likely from an old sports injury or other event, and symptoms are now just starting to present themselves. Chiropractor has done some hip, lumbar adjustments, and I have used fascial stretching and lumbar fascial release, and the symptoms have pretty much subsided, but does feel from time to time, but would love to have your insight on this, especially corrective exercises and other treatment options." So, really good question. There's a lot involved in this question. It's not a simple answer like you're going to do this one magic exercise or get the glutes to fire or stretch this one thing. This is a really in-depth question, and I like in-depth questions. So we've had some very severe spondies. I'm just going to say spondies now because I can't say listhesis, right? In our office over the years, and had some really good success. So coming a little bit closer here. So this is the MRI of a client who came in very young, early 30s, was an avid power lifter, having really crippling low back pain, numbness tingling down the leg, unable to sleep. Based off the history and the findings, definitely didn't sound good to me, so I ordered an MRI. And over here we have two different shots. In through here, she actually had two levels of a spondy. One up top where it wasn't too bad. It's 0.41 centimeters. And this is where it was really bad. Over here on that L5S1, it was 1.31. So just for context, I put a normal MRI in there as well, so you can kind of see what's going on in there. Really big issues from where we see, and these get mismanaged, misdiagnosed, and cause a lot of problems down the road. So what I want to go through is my whole process of figuring out what's wrong, the evaluation for it, what to treat, how to treat it, and load management. So Spondy 101. So I have a bunch of series of questions that I go through, and I talk about how I take a very thorough and in-depth history of what's going on. I have other videos on my channel for that if you want to check that out. But the first thing that I'm always looking for in a spondy is, was there trauma or no trauma? This is really key to me, because when there's trauma, the treatment itself isn't going to do as well because there's a lot of load that goes in there. So the history of the activities, asking them what they did in younger years. I usually see this in very competitive, like gymnastic people that did a lot of powerlifting and things like that. The history really gives us an idea of what's going on. And if there is no trauma, then I'm thinking that there's a dysfunction coming from somewhere else and I have to check other areas. When it's just a direct trauma, like, hey, they got in an accident and they got hit, they're probably not going to be a good fit for our office or our treatment because that area is really bad and really beat up. But if there's no trauma, that kind of comes in my wheelhouse of like finding the dysfunction. Next thing we do is, what functional tests do we do? And if you're part of the Facebook group, I have units in there with functional tests and evaluation. So all of these tests are in there, how to palpate, how to do that. So go back and check those out as well. The first test I look at is lumbar flexion. It's basically how your spine is bending. Another one I look at is straight leg raise, where we see how your hamstring is lengthening, if there's some sciatic nerve involvement, all those type of things. Another one that I look at is actually how your quads and your hip flexors are lengthening. And the last one we look at is overall hip flexion. When all of these tests are limited, they put more force into the spine. The spine tends to be the area that gets really beat up because other things aren't functioning correctly, especially if we're looking at a non-traumatic type of injury. So based off these tests and these findings, I'm able to tell which structures to treat. Now, where I'm really going to get a lot of information is on this lumbar flexion test. And usually, and we'll come back over to the TV, I want to see so you can see what our testing looks like. So the first test that we look at, this is back on the initial evaluation, and I talk about this in the Facebook group and show you how to do this test. But essentially we can see how flat everything is through there. and in there as well. This no flexion at all moving in that spine. And this is right where that spondy is. So essentially what happens is everything above that has to work a lot harder, and then everything below that does as well. So this is where you're going to find a majority of that dysfunction. Now, when we got in there and started cleaning it up, this is what it ends up looking like a few months later. You can see how we're actually starting to flex in there, get it to move, and you can see this as well in here where that's the pre-treatment, and then through there you can see how the both ends of the pencil are starting to come off, and that's really starting to bend better. You can just see how this was really straight and in through there. So the key that you always want to have is you want to have tests to determine if you're making progress. We don't do that in musculoskeletal care. We're just like, hey, how do you feel? And we don't know. When you have tests and you can show a client that and show them that they're getting real results, oh my God, they'll be your best friend. They'll tell everybody about you. So now we know which functional test to do based off the dysfunction that we find. Now, what I treat in this whole case and what we saw, this took a couple months to really get it in a good place, but that's just what it needed. So the first thing we ended up treating was a lot of the deep lumbar erector muscles, and really in the TL junction in there as well. That really started to get some of that pressure off of that the spondy down low. And the next thing we did is we ended up cleaning up a lot of the sciatic nerve entrapment. So the sciatic nerve can get caught in the muscles deep in the butt, especially on the gemellus and then through the hamstring. So we cleared that up as well. Next thing we cleaned up was the rectus femoris. That tends to get really bogged down, especially when they're pulled forward, and it will pull on that iliacus as well. I did not treat psoas. Psoas doesn't actually need to be treated. A lot of people think psoas does, but it's not the problem. Usually it's in the iliacus and then through the rectus junction. So we got that functioning better. Another area where I looked, and nobody really addressed this, and most people don't, is in the thoracic spine, specifically the erectors up top. But then what we also treated was the intercostals, because the intercostals are actually a stabilizer muscle in there. When you have a really bad spondy, you got to get all the stability that you can have. So cleaning up that thoracic intercostals really helped to give some of that stability to get the pressure off, because the goal of the treatment is to get the pressure off of the dysfunction down there. And lastly, we ended up cleaning up adductor magnus. When adductor magnus is getting overused, the hip doesn't function correctly, it puts more force on the spondy. So spondies without trauma, you got to clean up everything else because there's a dysfunction going on in there. Now, activities to avoid. Definitely loading and prolonged spinal flexion. So this patient that came in for us was a power lifter, and that's why there was dysfunction in there. And when you go into that flexion, what it does is puts more wear and tear up top and puts more pressure on that area down there and progresses that. Another one is just long hold extensions, like into that cobra position. A lot of people are like, well, if you just go in that position, the bone will go back in place. No, you're just jamming the disc and pissing everything off. And the next one is just weighted rotation. You don't want to do anything where you're weighted in your rotation. So what to do for exercises? I don't prescribe a lot of corrective exercises because if you fix the tissue, you don't need to. You can go back in and just get functioning normal. And this is what I call my be a human exercise routine. You always want to have, when you're doing an exercise, some type of push, some type of pull, some type of lunge, and a type of carry. That keeps you in spine neutral, which is really good. I'm a huge component of the lunge as opposed to a squat or a deadlift because it keeps your spine very neutral and keeps you from putting more force and trauma into that area. And this is the one where everybody fucks up. This is where we cause a lot of problems. You have to take control as a practitioner, and you have to manage load. People with a spondy that did it to themselves and more trauma, they're hyperactive people. They want to do a bunch of stuff. And the same thing as the question in here, the guy does everything, yoga, golf, Pilates, whatever. The problem is they're doing too much. When your load is more than your capacity, you're going to be injured. So you have to take control and let them know that you're fixing it. But if they don't do their part and they're doing too much, it's not going to work. And these are the same clients that are like, oh, I did all this treatment with you, but it didn't work. It's no, it did work. You just didn't follow the process. You have to be a leader. Quit trying to be the friends with your patients and your clients and be the leader. Tell them what they need to hear and fix the problem. So that's my spondy 101. There's a lot going on in there. There's a lot of resources in the Facebook group. You can check that out. And this is not a simple get the glutes to fire and it's going to be good to go. No, there's a lot more deeper layers in that. And if you're giving people a label or an evaluation of tight, weak, not firing, you're missing the boat because you need a tissue-specific diagnosis for what's going on. So thanks for the question. I will see you guys on the next one.